Hello, hello. Welcome, everyone. We are here today for Empowering Black Women with MS and Lupus. We're so glad you're here. My name is Ashley Ratcliffe Lundy. I am We Are Ill's Director of Communications and a fellow multiple sclerosis thriver.
And hello, I am Nicole Jones. I am the project manager here at We Are Ill.
And over the next 4 days, we are holding space for you, for your questions, and for the full truth of what it means to live with MS or lupus as a Black woman. The goal of this webinar is to help build your confidence with self-advocacy. This isn't a webinar where you sit back and absorb. This is a community. You'll be asked to engage, to share if you're comfortable, and to leave with tools you can actually use. So this is how this week is going to work. So today we have our clinical experts. We have a wonderful neurologist and a wonderful rheumatologist. Tomorrow we'll go inward with group therapy. Day 3 is our Ask the Nurse session on day-to-day care, and then we'll close day 4 with our case manager on navigating the healthcare system. Every session is about 60 to 90 minutes, and every session has space for your questions. So let's get started with some housekeeping notes. So we would love for you to participate. We want you to get all your questions asked. So please type your questions in the chat at any time and we'll answer them throughout. If you'd like to ask a question out loud, feel free to raise your hand and then we'll take you off mute. Cameras are optional for this session. We'd love to see your face, but we totally understand if you would just prefer to be off camera. I don't know, maybe you're cooking in the background, totally fine.
Yeah.
Um, a note on what we can and can't do here. So our doctors are going to be sharing general medical insight, and so it's not personalized at all. Please bring your specific questions to your specific doctor, medical care professional. Um, but please ask questions that will help you understand how to advocate for yourself. Of course, be kind, be curious. We're all here to learn.
Huh? Oh,
Oh, and then really quickly, this session's being recorded. It's going to be shared after each session will be shared except for the group therapy, and then it will eventually be uploaded to our YouTube channel. Um, and then Nicole, do you want to take it away?
yes. So today you get to choose your path. You have a choice today, and we have two breakout rooms, one for our MS community led by neurologist Dr. Deja Rose, and one for our lupus community led by rheumatologist Dr. Ashira Blazer. So both rooms are covering similar topics, what to understand about your condition, how to advocate for yourself, when to push back, but tailored to your diagnosis. And in a moment, the producer behind the scenes working on the magic will move you into the room that you select. So even if you're caring for someone in one of those conditions and you want to choose based on that and who you support, that is totally fine.
So yeah, I think for those who live with lupus, care for someone with lupus, you'll stay in the main room, and then the MS girlies or those caring for people living with MS will go into the breakout room 1 with Dr. Rose and I.
Alrighty, so I'm gonna go ahead and open the breakout room if that's okay, Ashley, and you will go ahead and go in along with Dr. Rose.
Sounds good.
Awesome. And so everyone, if you would like to join the breakout room with Dr. Rose, you'll look on the toolbar on your screen and you should see an option that says breakout. And so you'll select that and then hit join beside the breakout room. And if you're having any difficulty, feel free to drop your name into the chat, letting me know that you want to join the breakout room for MS, and I can happily place you in there.
Welcome everyone to the Lupus Room. We're excited that you're here. As Ashley introduced earlier, we are breaking out to do for two different sessions. So again, this is the room to discuss everything lupus when it comes to empowering Black women within this space. And again, we have Dr. Ashira Blazer. She's a rheumatologist at the Lupus Center at the University of Maryland. And so she's going to cover a lot more details on what that means and a lot of the themes that I talked about earlier on how to advocate for yourself, what to look for. So, Dr. Blazer, I will pass it on to you. Thank you. Thank you for joining us.
Of course. Thank you so much for having me. It's wonderful to be here in this space this evening. So I am just going to jump right in. Let me just share my screen. Okay.
And then
Great.
while you're pulling it up, just to reiterate some of the housekeeping, just to answer some of the questions that don't necessarily fit the standard appointment and to help us understand conditions of mixed diagnosis. So just be open, be free, whatever questions that you may have. But again, be mindful we cannot answer any specific medical questions that you may have that goes to your doctor. But anything that is general that is not specific to a specific diagnosis or anything that you're looking for a prescription of any kind. We can't do that here, but we will make sure we get your questions answered to the best of our ability. All right.
Absolutely. Thank you so much for that, Nicole.
Mhm.
Um, okay, great. So I'm Dr. Ashira Blazer. I'm an assistant professor of medicine at the University of Maryland, Baltimore. I also co-direct the Lupus Center and specialize in seeing lupus patients and doing biomedical research that improves the lives of patients living with lupus. So I just want to jump in just to talk about the different conditions that you may hear connected to the word lupus, right? So most of this talk is going to be pertaining to systemic lupus erythematosus, which is this quintessential autoimmune condition where the immune system becomes active against your own healthy tissues and it can affect multiple organ systems in the body. But there are other terms, there are other conditions that may have the term lupus attached. And one of them is cutaneous lupus. So some of you may have heard of this. So this is where you have that positive lupus blood test, and then you have rashes, usually rashes that are sensitive to the sun, that are very characteristic of lupus. But apart from the skin involvement, you don't have anything else. Now, a small portion of those patients will go on to develop systemic lupus, but that's only 5 to 20%, right? And then there are these other conditions that aren't exactly the same thing, but also carry the name lupus. So one of them is drug-induced lupus, which is a drug reaction that can cause an autoimmune um, syndrome, but that syndrome goes away when you stop that medication. And then there's neonatal lupus, which is actually not true lupus. It's when someone who has the blood antibodies for lupus then gets pregnant, some of those antibodies can transfer into the circulation of the growing fetus, and that can cause a rash in the fetus or in the baby when they're born, or it can cause a heart condition called heart block. This is something that also goes away usually around 6 months after birth. Okay, so getting into systemic lupus, I am willing to wager that many of you here have experienced systemic lupus or know someone who's living with systemic lupus. So this autoimmune condition, and essentially it is an overactive immune system. So the blood carries white blood cells. The white blood cells are the immune cells. And so these are the ones that are causing the inflammation. So really anywhere the blood can go, lupus can go. So, most people who experience lupus will have symptoms related to just their immune system being active. So, it's similar to when you have a bad flu or cold, you may feel real run down, you may have brain fog, you may feel extremely tired or have a hard time doing the things that you would usually do. And that's because your immune system is active, right? And then you have symptoms based on where the immune system is active, where those white blood cells have gone to cause inflammation. So, very commonly, people who have systemic lupus will have some skin involvement. So, whether that be the butterfly rash that we all think of with lupus or a discoid rash on the skin, many people will have joint pain and joint swelling, especially in the morning time. But then there can also be internal organ involvement. So, there can be inflammation around the heart or lungs or inflammation in the kidneys, which we'll talk a little bit more about. Okay, so I want to talk a little bit about disparities in lupus because I think that this allows us to understand the kind of things that affect lupus outcomes, right? So this is data from a study that was sponsored by the CDC all across the US and in these different regions, so including New York and Georgia, California, Michigan, and the Indian Health Study. They asked which groups of people have lupus and where's the incidence and prevalence the highest. And it turned out that across the US, all non-white groups were more likely to have lupus than white patients. And for the most part, that was 2 times as likely, but in some places, especially for Black women, that was about 5 times as likely. And the disparities aren't just in getting lupus, it's actually also in the severity of lupus. So this is a study that was done taking a look at the top 10 causes of death for women living in the US due to chronic disease. And one thing that I think people underappreciate is that lupus was in that top 5 for all women ages 15 to 24. But for Black and Hispanic women, it actually stayed in the top 10 through to age 44. So it's not just that this is something that's more prevalent, it's also something that can be more severe. Okay, so in talking about these racial differences, I really want to frame the conversation because sometimes when people think about race, they think about biologic differences, and that is just not reality. Race is not biology. It's not genetically discrete. Humans reproduce with each other and make more babies. It's not something that is biologically measured. Race is a positioning in society, right? It is a social construct, but when people are positioned in places of relative vulnerability in society, race can become biology. So when we frame it this way, we're going from race-based, meaning race is the risk factor, or there are biological differences rooted in race, to race conscious, right? Understanding how social and power constructs influence health. And I think this is very helpful because we can support people when we think this way, and we can also understand the factors that influence outcomes and then advocate to make sure those factors are not affecting us specifically. Okay, so one thing that I want to introduce here, because anyone who's living with lupus knows this, there are times where you feel fine and there are times where you have flares, right? So lupus, and this is something that is really difficult because sometimes you don't know what to expect, right? So you'll feel reasonably well, you'll have a flare up, you'll come back, you'll have a flare up, you'll come back, you'll have a flare up, right? Now, one thing about these flares is that they cause inflammation. And just like if you burned yourself and you had inflammation on your skin, that inflamed area can heal with a scar, right? So each time you have these flare-ups, there's a risk that that inflammation heals with a scar wherever you had the flare, right? Whatever you were affected by the lupus. And that scarring process is what we call organ damage. So this red line here is that over time, the body can be affected by this repeat injury, and that can cause problems over the lifespan when you have lupus. So the reason why we want to prevent these flare-ups is because we want to prevent that organ damage from building on itself. Okay, so one thing about lupus is that it is a disease that invites other chronic illnesses, meaning when you have lupus over time, you're more likely to get cardiovascular disease, or, if you've had maybe steroids, you're more likely to get diabetes, things like that, right? So what I'm showing you here is a study where authors took about 1,000 patients with lupus, and they looked at patients who were white and patients who were Black. And they asked, if we look at all of the other medical problems that these patients have, are they more common in white patients than in Black patients? And one thing that you'll notice right off the bat is in the bottom square, the Black patients were about 10 years younger than the white patients. But what they did was when there was ever a disease process that was more common in white patients, they put these right side up triangles on the graph, right? And anything above the red line is actually statistically significantly different, right? So I'm showing you first all of the right side up triangles, right? So these are all of the conditions that were more common in white patients living with lupus than Black patients living with lupus. Here are the upside down triangles. All of the health conditions that are more, it is crazy to see this together. But one thing that you have to understand is that a lot of times it's not the lupus, it's the things that go along with the lupus. So it's important to make sure you have your primary care doctor paying attention to things like hypertension, right? Things like diabetes, things like metabolic syndrome. All of those things are going to go into whether or not you can live well with lupus, right? And this is a major harbinger of disparities in lupus. Okay, so the next thing is when you get diagnosed with lupus matters, right? People who get diagnosed earlier, who get treated earlier, do better. And of course, time to diagnosis tends to be longer in ethnic minorities. So why might that be? So when you think about who gets lupus, it's more common in women of color, right? These are groups of people who have more of a hard time seeking and maintaining health care, but also a hard time being listened to once they get health care, right? You have to go into a doctor who has the time, who cares to listen to your symptoms, who can understand, today she's saying she's feeling very tired. 2 months ago, she said she had joint pain, right? Today, she says she has a rash. 3 months ago, she said that she had some hair loss, right? And here are some labs that can go together, right? So, someone who can put all the picture together and say, I think that this might be lupus. And then you have to be referred to a specialist who can get you to treatment. That is not something that happens as often in Black and Brown patients, and particularly in women, right? Often patients of color and women are not listened to at the right rate. And so it's really important for us to understand what this looks like so we can also advocate when we see these symptoms. Okay, so just to drive home the point that when you get diagnosed matters, this is a study that looked at over 8,000 people living with lupus, and they grouped people into buckets, right? People who were diagnosed early, so they had symptoms and they were diagnosed within 6 months of having symptoms, and people who were diagnosed late. So these are people who had symptoms and it took over 6 months to a year for them to get diagnosed. And what the authors found was that who not only more likely to have, they also were more likely to have severe forms of lupus. So lupus that affects the kidney, lupus that um, is associated with other autoimmune diseases, lupus that also affects the bones and bone health, right? So, so it's that we get those later, because later we get to diagnose more than we've had the can then with our and okay. So another thing that is actually associated with worse outcomes in lupus is communication with the doctor, right? So this is a study that took a look at lupus patients across racial and ethnic background, and they found that when the patient left the appointment and said, that felt really rushed. I didn't feel like I connected with my doctor. I didn't feel like they listened to me. I don't understand my healthcare plan. Patients who felt that way were much more likely to develop that organ damage than patients who did not feel that way. And so this really shows you that most of the care that you receive actually comes from you, right? You think about when you're in the doctor, like the percentage of time you're actually in the doctor's office versus you're caring for yourself at home or your loved ones are caring for you. Most of the time is self-care. And so it's very important that you feel like you understand in that doctor's appointment so you know what to do for yourself when you leave, right? And so if you're not feeling listened to in your doctor's office, this is not something to brush off. This is something that can actually impact your care in the long term. And so it's very important for you to either find someone who is listening or to have someone on your team who's able to make sure that what you're getting from the healthcare system is what you need. Okay, so now I'm just going to go into some of the main kinds of medications that we use for lupus, right? Um, the first is hydroxychloroquine. I'm sure many of you have heard of this. That's Plaquenil. I call this vitamin P for lupus patients, right? If you can tolerate hydroxychloroquine, you should be taking hydroxychloroquine. It is inexpensive. It works very well. It prevents those flare-ups, it prevents that organ damage, and people who take hydroxychloroquine get fewer of those other medical problems along with their lupus, less likely to have cardiovascular disease in the long run, less likely to have diabetes in the long run. It's so, so, so important. I cannot stress enough to take hydroxychloroquine. We'll talk about that again because it's so important. The other thing is long-term steroids should not be the move. I'm going to say that again because it's so important. Long-term steroids should not be the move. So a lot of doctors in the past, and honestly, some currently, have thought that it was reasonable just to put someone on steroids and then leave them on steroids, right? Steroids are your frenemy in lupus. They're really good at bringing down inflammation quickly. But if you're starting steroids, you should be starting something else that's going to replace that effect to calm the immune system so that you can take away the steroids, right? I say that because steroids cause a lot of the long-term problems that we see in lupus, including the diabetes, the heart disease, the increased risk for bone thinning and osteoporosis, right? So many of those chronic problems that we saw in that graph are directly related to taking steroids. And people who take steroids, even doses of 10 milligrams, right? People who take that every single day for long periods of time get sicker and don't live as well with their lupus. So, you know, it actually blows my mind the number of people who I've gotten who were just like, oh yeah, my last doctor said I should just take, 15 milligrams steroids. And if that helped me, then that's fine. That is not fine. So if you learn, you need to be seeking other plans with your healthcare provider if it's the case that you need that, right? Okay. Now, when we think about the something else that we can add to get rid of steroids, there are two main buckets. So one is these conventional medications. So these are medications that help to calm the immune system, but they work very broadly, right? These are tried and true older medications, and they're not so targeted, right? So I'm putting some examples there that you may have heard of or not. But then there are also targeted medications. So one thing that's really exciting about practicing healthcare and taking care of lupus patients right now is that we have so many new options. It's wonderful. We have good clinical trials. We know how to see whether or not something's helping or hurting. And we have these medications that are targeted to the kind of inflammation that we see in lupus, right? These are sometimes injections or infusions. There are different regimens and different intervals for taking these medications, but I'm finding that people are doing much better when they're able to have these options, and it allows us to take away those steroids and help our patients do well long term. Okay, hydroxychloroquine again because it's so important. It's very, very important. Okay, hydroxy, it's the most common medication that we use in lupus. We used to use it for malaria. Are called chloroquine or quinacrine, associated with fewer flares, lower mortality, decreased risk of blood clots, less organ damage. So I'm showing you on the right-hand side, these are panels from this tool called HCQ Safe. And I actually use this with my patients because it really shows how hydroxychloroquine help. All right. So on each of the sides here, you see a scenario where 100 patients living with lupus uh, are not given hydroxychloroquine. And on the right side are 100 patients living with lupus who are given hydroxychloroquine, right? So over 2 years, we expect of the patients who are not getting hydroxychloroquine, 72 out of 100 patients to have a flare up of their lupus. Compared to people who are getting hydroxychloroquine, 51 out of 100 would have a lupus flare up. So we save 21 flares just by taking hydroxychloroquine. So this is deaths, right? So over 3 years, we expect out of 100 patients who are not taking hydroxychloroquine, 17 deaths. And out of 100 patients taking hydroxychloroquine, only 5 deaths, saving 12 deaths over 3 years just by taking hydroxychloroquine. for blood clots, like blood clots in the leg or going to the lungs. We would expect 30 in the patients not taking hydroxychloroquine, only 5 in the patients taking hydroxychloroquine. We saved 25 blood clots over 20 years just by taking hydroxychloroquine. All right, and what about that organ damage that we've talked about? So over 8 years, in patients not taking hydroxychloroquine, we expect 73 of them to accrue that organ damage, only 27 in the patients taking the hydroxychloroquine, right? So this just goes to show you that this very inexpensive, well-tolerated, for the most part, medication really can improve outcomes, right? So one thing that this tool actually shows as well is that eye toxicity. So I think a lot of my patients, whenever I say, you have to get your eyes checked and hydroxychloroquine can affect the light sensing nerve in the eye called the retina. Over time, it's a cumulative thing. They say, oh, I don't want to take that risk, right? Um, but in this same time period, so about 8 to 10 years, only 1 out of 100 would have that complication. And as long as you're seeing your eye doctor, the eye doctor will find the changes before it ever affects your vision. So this is something that, you can prevent that bad outcome from taking hydroxychloroquine. And the default is not nothing. The default is having lupus activity that can harm your body. Okay, alrighty. So now that we've talked about medications, what can you do for yourself to prevent flare-ups of your lupus, right? So this is directly out of our guidelines, and it really shows that you can do quite a bit for yourself at home to also, in addition to your medications, keep you healthy, right? One of them is protecting your body from the sun, right? So the rays of the sun can land on your skin, damage your skin, even when you're not seeing like a burn. It can damage skin cells or the immune cells just under the skin, and that can cause you to have a flare up. So even if you have a deeper skin tone, it's very important to protect yourself from the sun. We say 2 tablespoons of sunscreen. If you're in the sun, like on a vacation or something like that, you reapply every 2 hours, at least SPF 30, right? And there are a lot of different options that don't leave like the chalky feel over your skin. Very, very, very important. I cannot tell you how many patients I have who are like, I went on vacation and I came back and I had this flare, right? Make sure you're protecting yourself from the sun. Staying up to date on your vaccines, super important. Many of the medications that we use in lupus can cause the immune response to be weaker. And so that means that you're at higher risk for infections. But also, when you have lupus, your immune system is worried about the wrong things, right? So your immune system, instead of going to, look for bacteria and viruses, starts to look for your skin or your joints, right? And it's preoccupied with self antigens or your own tissues such that it can't mount a response as well to those infections, right? So it's extremely important for you to stay up on your vaccines and protect yourself against common viruses. Move your body. And here, a lot of patients say, I hurt. I don't want to move my body, which makes a whole lot of sense. I'm tired. I don't want to move my body. That makes a lot of sense, right? But I think you just have to reimagine what it means to move your body, right? Meet yourself where you are. If all you can do today is take a walk for 5 minutes, that's your moving your body. If you can do some yoga in a chair, that's your moving your body. It doesn't have to be a heroic effort, but if it's something that you can do with the consistency of, based on the energy that you have, start there and then just build from there. The more you move your body, the more you're able to maintain your muscle mass, the better you're going to live long term with your lupus. Smoking. And this is smoking everything, okay? Because a lot of times I say smoking and everyone's like, I just smoke weed. Smoking all the things, right? So um, whenever you're inhaling sort of foreign substances like that smoke, those carcinogens, get into your lungs. They meet your immune cells, and your immune cells say, something is wrong here. I'm going to make an inflammatory response. People who smoke are more likely to get lupus if they're predisposed to lupus. People who smoke and have lupus are more likely to have lupus flares. Many of those other medical problems that we talked about that can go along with lupus are more likely to happen if you smoke. One of the most important things you can do for your health is quit smoking if you smoke. All right. Maintaining a healthy weight is important because that is going to affect how you can move. It's going to affect your joint pain. And then also, you know, insulin resistance metabolic syndrome directly affects the immune system. So when you can lose some weight, you can improve the how well your medications work and how many flare-ups you have. And then also minding your heart, right? So making sure your blood pressure is controlled. If you have high cholesterol, high blood sugar, making sure those things are well controlled. Okay. Now, let's talk about what your doctors can do for you and why it is that we're seeing these health disparities, right? There are biases in healthcare. There are biases in the way that people of color are treated. And so this is a study out of Georgia. So at Emory University, the Georgia Lupus cohort. And what they did was they asked patients, have you ever heard of advanced therapies? Those are those therapies that are more targeted for lupus that I talked about in the beginning. And compared to white patients, Black patients were half as likely to ever have ever been told about these medications. So only 25% had been told about these medications, and they were less likely to be prescribed them, right? So this really matters because you have to understand all of the treatment options that are available to you in order to make the appropriate decision. And of course, not all patients are going to respond to all things. And so if you don't even know about these medications, you're not able to take advantage of the advances. The other reason why this matters is because people who don't get those advanced therapies or who are not controlled on the other medications that improve lupus tend to get more steroids. So this is especially true for people who maybe don't have a rheumatologist and they're getting their care in primary care, or if they have a flare up, they go to urgent care, they go to the ER. The first thing that happens is someone's going to prescribe you some steroids, right? So this is a study that looked at over 6,000 people living with lupus, and these were people who were all on Medicaid. So I point that out because these are all people who had socioeconomic needs, right? So it's not like, certain groups of people were, more likely to be poorer than other people, right? Everyone here had some socioeconomic need, right? So what the author said was, were patients of different racial backgrounds more or less likely to be getting chronic high dose steroids? And on average, white patients were given about 4 milligrams per day of steroids, but Black, Hispanic, and Asian patients were given on average 7 milligrams per day of steroids, right? So, of course, some people were higher or lower than the average, but that 7 milligram figure is enough to cause organ damage, right? So, it's not just that patients are not learning about the medications that are available, the newer ones, it's that what's replacing this in Black and brown patients are steroids, which we know lead to poorer outcomes. Okay. Again, because it's so important, steroids help fast, but too much causes harm over time, right? When you take steroids chronically, it leads to weaker bones, those osteoporotic fractures. It leads to higher blood pressure and strain on the heart. It increases the risk of infections. It also leads to body changes like weight gain, mood changes, diabetes, and also wrinkles, which nobody wants, right? So it's very, very, very important that you work with your rheumatology team to lower steroids if that's what you're taking primarily. Okay. So I'm going to wrap up with a word about lupus kidney disease or lupus nephritis, because it's one of the things that is very common in lupus and that you need to be screened for and treated for pretty immediately if you develop it, right? So what lupus nephritis is when the inflammation of lupus affects the kidneys. So the kidneys are primarily responsible for filtering your blood, getting rid of the toxins. They help you make urine. And it's a major way that you stay healthy over time is that you have functioning kidneys, right? So about 50 to 60% of people who are living with lupus develop lupus nephritis. It's most common within the first 5 years of diagnosis. And in fact, some people are actually diagnosed at the time that they develop lupus kidney disease. Fewer than 40% of people who get lupus kidney disease achieve complete remission within 1 year. So that is correcting the kidney function and also correcting the protein in the urine. And about 30% of people living with lupus nephritis progress to end-stage kidney disease, meaning they will go on to need a kidney transplant or need dialysis. This is changing, thankfully, because we have new medications. And, and this is something that is making me very hopeful. But these have been the historical statistics. Okay, so one thing that I also want you to remember. So the first thing that I want you to remember out of this talk is take hydroxychloroquine if you can. The second is do not take all that steroids. Get off the steroids if you can. The third is get your kidneys checked regularly for lupus. You need to have your kidneys checked at least every 6 months if you have lupus. Okay. So how does your doctor check your kidneys? First is blood pressure. And this is something you can actually do at home because when your lupus becomes active in your kidneys, one of the first things that can happen is your blood pressure was normal and suddenly it's high, right? So making sure your blood pressure is checked. There are blood tests. So you'll check your lupus activity. So that's those complement levels. Those are immune proteins made by the liver that can break down and that those numbers, the C3 and C4 numbers fall down when your lupus is more active. And then double-stranded DNA antibody levels. So those are those antibodies that are made by the immune system. Those levels can come up when your lupus is more active. And then the last thing is urine tests. And this is one of the most important things, right? You should leave a urine sample for your doctor. Your doctor should take a look at how much protein is in the urine, right? If you have too much protein, over about half a gram per day in the urine, that is a signal that lupus could be affecting your kidneys and you need to be looked at further, okay? This should happen at least every 6 months. I do this for my patient every time I see them, all right? Because the earlier you catch this, the earlier you can treat it. And the earlier you treat it, the more likely you are to get a complete remission. And that is going to directly impact your long-term outcomes. Okay. So now that we've talked about what needs to happen, how do we get there? So it's very important for you to build good communication with your care team, right? So again, sometimes this is something, I think we all grew up, I don't know if maybe I'm aging myself, but I grew up with my parents watching House MD and me watching House MD, right? And everyone's like, oh, well, he's kind of a jerk, but he's so smart and that's okay. It's not okay. Don't go to a doctor house, right? If you if you cannot communicate with your doctor, things are not where they need to be because you are the one who's caring for yourself, right? So ask yourself these questions. Am I being listened to? Your concerns deserve time and attention. Do I understand my health, right? What's going on? Are these explanations something that I can repeat back if I had to? Do I feel validated? Am I going in and my doctor says, okay, these symptoms are real. We're going to take a look. Or does my doctor like brush off what I'm feeling, right? It's very important that you feel validated and your symptoms are validated. Do I feel respected, right? Is there trust with my physician? Does my physician respect me, right? And does my doctor show empathy? All of these things are important. You have to feel cared about. You have to feel respected and validated. You have to understand your care plan because, again, most of the care you're going to give is you're going to give to yourself, and we can't have these communication barriers in that relationship. Okay. So I also just want to show you that the CDC has partnered with the American College of Rheumatology to create this Healthy People with Lupus 2030 goals. And I think it's really nice because it outlines what screening should happen and how often it should happen, right? So it kind of helps us level set for how lupus care should be, right? So one is if you can tolerate hydroxychloroquine, you should be taking hydroxychloroquine, right? Keeping steroids low. So avoid prednisone above 7.5 milligrams per day for longer than 6 months, right? Ideally, no steroids, but certainly not above that 7.5 milligrams per day number for longer than 6 months. Check your kidney, blood pressure, blood and urine tests, looking for kidney involvement at least every 6 months. Check how you are functioning. One thing about lupus is that for some people, it causes disability. It causes it to be difficult for you to work. It causes it to be difficult for you to do the things that you need to do for your family. And if you are developing disability, this is something that your doctor needs to be checking and then also can refer you to physical therapy to really outline exactly how you're limited. And that can make sure that you get the resources you need to still be able to live your life, even though lupus is affecting your ability to work. And then depression. One thing about living with lupus is that it can definitely affect your mental health. And that is something that is extremely common in lupus patients. You should be screened for depression at least once a year. And if you're developing depression, you need to be treated for that as well. Okay, so in summary, is more common in Black patients, and it's more likely to cause chronic illness and even death. Disparities in lupus are largely caused by delays in diagnosis, overuse of steroids, bias in the patient-provider communication, loss of care, and loss of access to care. If we can address these things, we can address how well you live with lupus. We can make sure that you're living a normal length of life, given that you have lupus, right? Lupus nephritis or lupus kidney disease occurs when lupus inflammation affects the kidneys, and it should be screened for every 6 months. And effective patient-provider communication can be life-saving. All right. So I'm going to stop my share here, and hopefully we can have a great conversation about this.
Yes. Can we just throw some emojis? Can you guys do there? We go, some graphics. Thank you, Dr. Ashira Blazer. That was phenomenal. That was very insightful. I know I learned a lot from that too. We are definitely going to open it up for questions in just a moment, but I did want to have just have a quick discussion on some of the outlines from your presentation and just in general from our community before your actual presentation. So thank you, thank you, thank you for that. I can tell you put your heart into that, and that's exactly what we want and the information we need.
For sure. For sure.
So let's start with just a few questions and then we'll open it up. I see a number of questions coming in the Q&A. I see some in the chat. So these people got a lot of stuff and they said this was very informative. But what's one symptom patients often minimize that they should absolutely speak up about? You named a lot within your
Mhm,
presentation,
mhm,
and even this disparities when it came to advanced therapies and things of that nature was also eye-opening for me. But
mhm.
what's one thing that you have noticed?
Yeah, I would say actually blood pressure. So, and I think this is also something that doctors don't pay enough attention to either. Like, we all just get used to people having high blood pressure and whatever, but having high blood pressure when you have lupus, when you think about lupus, these white blood cells are flowing through your blood vessels, and then they have to leave the blood vessels to get into your skin or your joints or your kidney, right? And that leaving process can damage the blood vessels, right? So when you also have high blood pressure damaging the blood vessels, you have an increased risk of these chronic medical problems that we talked about. And especially if you have kidney involvement, the blood pressure needs to be well controlled. And I think you know, often we just sort of poo-poo it, but that is something that we really need to be paying attention to.
Okay, that's really good. Because my follow-up question was going to be, what's one question every patient should ask their rheumatologist?
Mm,
Outside of the cadence that you gave us, where every 6 months you're doing these specific checks, it sounds
mhm.
like if you're in that office, you need to ask about your blood pressure and I guess your blood pressure
Yeah.
charts. Like, what's the best
Yeah,
question
your
for them
blood
to
pressure,
ask?
and then also just the disease activity. And like not every doctor does this, but I am really big on measuring your disease activity every time you come in, right? And the reason for that is lupus can affect so many different parts of the body, right? Today you may have, some hair loss and some sores in your mouth, and tomorrow you may have, some rash or some joint pain, right? And I think unless you're being very methodical, it's not easy to understand whether or not your medications are working the way they should be, right? And so I do something called low lupus disease activity state, which is three different goals. One is that steroid goal. So I want the prednisone to be less than 7.5 milligrams. The next is actually a series of questions that help me understand if lupus is active, and then also if, how the blood tests are looking. And then that has a point system on it, right? So I want there to be fewer than 4 points on that activity scale. And then I will give a scale as well from a 0 to 3, 0 meaning I think there's no activity, 3 meaning I think there's all the activity, and I want my scale to be less than 1, right? As long as my patients are meeting those goals, then we don't need to change the medications. If they're not meeting those goals, we need to change the medications. And the reason why I do that is because there's actually data to back this up, right? So there are patients with lupus who don't get extra internal organ involvement, who don't have shortened lifespans, right? And those patients are the ones who can meet that criteria at least about 2/3 of the year, right? So if I'm following my patients and I'm measuring this every time, and 3 months go by and you're not meeting that, I need to be making some moves, right? Because as long as my patient can meet that 2/3 of the year, I can say you're going to live a normal lifespan with lupus. I can say you can have a healthy pregnancy with lupus, right? I can say you're not going to have those chronic medical problems given that you have lupus, right? And I think it makes a really big difference when you're being objective about it. Because it's so easy to just somebody comes in and oh, that's nothing. Just wait for the medication to work a little longer. Oh, well, we just da. And in that time where we sort of hem and haw, patients actually have consequences, right?
That's great feedback because then this part that you just mentioned helps with the empowerment piece, which is the whole
Mhm.
premise of this series. How do
Mhm.
you empower yourself? And now that you have the data, now that you have the information, and the history of your condition, what then do I do? Like, how do I map this out? So you just gave like the how, so we feel a lot more empowered. So if we do get that pushback that we talked about earlier, then
Mhm.
that helps us then become better advocates for ourselves in
For
that
sure.
room.
Yeah,
Um,
actually, I
yeah.
have patients who were seeing, I was in New York before this, and then now I'm in Baltimore. And so I had patients who were seeing me in New York, and then somebody came in and they were like, well, what's my disease activity? Am I an LLDS? And they were like, oh, I don't do that. And they're like, Dr. Blazer didn't say that. And they came right to Baltimore to see me.
That is a good one.
So
That
my
is a good
patients
one.
know, they know what's
Yeah.
my disease activity.
Yeah. Are
So,
there other ways for them to become stronger advocates in that room based on this information that you just shared?
yeah, I mean, I think sometimes people don't feel comfortable asking why something is being recommended or saying when something's not working for them, right? If it doesn't work for you, it doesn't work. Right. I think a lot of times people are worried, my doctor put me on this drug and like this is my only option, or they think this is the best option and I'm having XYZ side effect, but I can't really speak up. Speak up, right? Because it's so much more important for you to speak up and find something that works for you than for you to be taking something that you're not tolerating and then, well, now you're not taking it as often and then your lupus flares up, right? So I think just writing down when you're not in that face to face with your doctor, writing down what it is that you need to be addressed, making sure that you're bringing that list to your appointment. And if you still have a hard time speaking up, making sure you have someone with you who can speak up on your behalf, like a loved one.
That's a great response. So then that could be a two-way street where if you don't feel confident speaking up, you may hinder yourself from asking those questions. But I think what you just gave is great advice. But then what if it's on the flip side where they don't feel like the provider is actually hearing them or seeing them? What are
Mhm.
some of the notes or conversations that they should have with that provider so they can help them and meet them where they are? Even if they might be uncomfortable having those conversations, and that might be where they bring in that other person. Like, what is some advice that they could do to have better conversations?
Yeah, yeah. So and not everyone has this luxury, but if you feel like you're not being heard by your provider, I would try to find another provider if you can. Now, if you can't, there aren't rheumatologists everywhere. Make sure you have another trusted provider who is advocating for you, right? So a lot of people who are living with lupus say, "Oh, well, I have to go to my rheumatologist all the time. I don't need a primary care doctor." Keep your primary care doctor. One, because they're going to look out for those other medical problems that can go along with lupus. And two, because a lot of times that person can also advocate, right? So say
Mhm.
you're having, you're having a symptom, you're not tolerating a medication, you don't understand your labs, you go to your primary care doctor and you're talking with them about that, they can then actually reach out to the rheumatologist and say, hey, we share this patient, this is something that's going on with them. Can we have this conversation? So they can advocate on your behalf, right? Same with, a social worker, same with a mental health provider, right? Try to find someone on your care team that you feel comfortable with and who can advocate for you.
Awesome. Awesome. Well, we're going to open it up to questions. Before I do that, one last question for you because I love the way that you talk about this. It seems very personal to you. It just feels like it's just you're in your nice and cozy space, learning and developing and helping other people grow and become better advocates for themselves. What actually, like, how did you get into rheumatology and what lights you up about this work specifically?
Yeah, so it is very personal for me. My family members have lupus. That's the reason why I became a doctor and certainly why I became a rheumatologist, right? So actually, when I was in medical school, I was like reading about lupus because I was about to take the test on this, branch of medicine. And one of my first cousins had skipped all of our holiday gatherings, right? And I was like, what's going on? And she's like, oh, I've been feeling sick. And I was like, oh, you have a cold, you have a flu. She's like, no, 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 I've been feeling very sick, right? And she was telling me her symptoms, and I was reading them from my textbook. My textbook was just sitting in my lap. I was reading them. And so I was like, I think this could be lupus. And I took her to my professor, and she got a diagnosis. And then I was sort of on her journey with her. And I just said, this is something that I need to. That I need to study. These are people who I need to help, and I need to learn more about this. And so that really informed um, my wish to be a rheumatologist, but then also the research that I do.
It all makes sense. Now look, getting the hearts and the and the emojis. All right, so we're gonna open it for questions. I do see a number of questions in the chat. I'm gonna start off with the one that was in our Q&A box, and then I'll go down the top of the list as much as we can. So here we go. So the first one that I see, it's anonymous, but what is the average dosage of a, and please forgive me if I butcher this. What is the average dosage of Plaquenil? For a patient with
Platinum. Yeah.
okay, with SL with mild SLE, and how often should you see a rheumatologist?
Yes. So Plaquenil should be, so we dose it at 5 milligrams per kilogram. So meaning there you should be taking 5 milligrams of the medication for every kilogram of body weight, right? So that dose for some people can be 400 milligrams a day. It can be 200 milligrams a day for some people. It can be 300 milligrams a day for other people, right? So the thing is, we don't want to go over that 5 milligrams per kilogram because when we do that, we can have an increased risk of that eye toxicity.
All right, so that one got answered.
Oh, and
Thank.
you should see your rheumatologist every 3 to 4 months, even if you have mild lupus, because you have to be screened in case the lupus changes.
Awesome. All right, I'm making sure I'm not mixing this up with some of the MS questions in here. Someone mentioned, so this was earlier during your presentation where you were going over the slide about steroids.
Mhm.
This is just more so a comment. They kept me on steroids for 5 years, on and off. Um,
That happens so much. It's really, I'm just like, we don't have to do that. I wish, yeah. I'm sorry.
Can Dr. Blazer explain the role of complements again when checking kidney function?
Yeah. So complement. So there are a number of blood tests that your doctor may do when you have lupus. So certain set of blood tests are just to see if lupus is affecting your body's general function, right? Are your blood counts low? Is your kidney function normal, right? And then we check certain blood tests to see if lupus itself is active, right? So these are blood markers of lupus activity. So the main ones there are the complement levels and the double-stranded DNA. Now, not everyone who has active lupus gets high double-stranded DNA and low complements, but double-stranded DNA is a kind of anti-nuclear antibody. So everyone hears about ANA or anti-nuclear antibody and a positive ANA and that being like the lupus blood test. But that's sort of an umbrella term, right? So there are many different kinds of anti-nuclear antibodies. And one of the kinds are those antibodies that are directed against double-stranded DNA, which is like the genetic material inside your cells, all the cells in your body, right? So those antibodies tend to come up. So your immune system makes more of them when lupus is more active, right? And when lupus is active, those antibodies, together with whatever they're trying to attach to, can start to break down proteins called complement. So, complement is a protein that's made by your liver. It participates in the immune response and it can be consumed, right? So, when your immune system is active, it sort of chews up that complement and then those complement levels fall down, right? So, whenever you have high double-stranded DNA antibodies and low complement levels, it gives us a clue that your lupus may be active. Lupus can do whatever it wants. So there are some people who have lupus activity even when those blood tests are normal. But if you're the kind of person who has those blood tests become abnormal with lupus activity, it helps us understand what's going on in your body. Oh, you're muted, Nicole.
Thank you for answering that question. Before we go to the next question in the chat, Rosalind, you have patiently
Yes.
had your hand raised. Let's get your question. You can unmute yourself.
Okay, thank you. All right, can we unmute her? Oh,
Mhm.
we can ask her to
Oh,
unmute.
I clicked it,
Oh.
but nothing happened.
Hmm.
Okay. If you put in the chat, I will find it. I'll let our virtual producer work on that. But I did try to unmute you. The next question from Candace, is lupus nephritis a thing that will eventually happen no matter what you do?
No. That is an important question. Not everyone who has lupus will develop lupus nephritis. So, about half of people who have lupus will develop lupus nephritis. It is uncertain how we prevent lupus nephritis from happening, given that you have lupus. However, people who get treated up front and early and people who don't have as much activity are less likely to develop lupus nephritis. So, it's one of these things where we are getting some sort of population-based evidence that being well treated early matters, but it's not necessarily something that's going to happen to everybody.
Okay, thank you. And this also was earlier from one of your slides. What are some of the biologics?
Yes. So there are a number of medications that are in this sort of class of biologics that have been approved for lupus. The first one that was approved was belimumab. And so this one basically prevents. So I talked about those white blood cells. There are different kinds of white blood cells, and they all sort of work together like a little army. The ones that are particularly active in lupus are called B cells. And so those B cells have to mature so that they can make all those anti-nuclear antibodies, right? And so what belimumab does is it prevents the B cells from maturing. It takes away the chemical signal that the B cells need to grow up and become the ones that make the antibodies, right? So that's one of the biologics. Another biologic is called Safnello. So this is a medication that, or anifrolumab is I shouldn't say the trade names. Anifrolumab is a generic name. So this is a medication that blocks the main chemical signal that promotes lupus inflammation. It's called interferon. And so what this does, and actually on my Instagram page, I like made a whole little video about like interferon and how it works and all the stuff. So feel free to go and look at that. But this blocks the chemical signal to called interferon that propagates the inflammation of lupus. And then another one that just got approved is obinutuzumab, which has been approved for lupus nephritis, and it is really working beautifully for me. So I'm like very excited about it. Also, you only have to give it every 6 months. I'm not like a spokesperson for the company. I'm just excited about it. But essentially, what this does is it it takes away those B cells, right? So it allows the immune system to recognize those B cells and get rid of them, right? But especially the ones that are making these antibodies. And so it really brings down lupus inflammation well, and it can affect multiple outcomes of lupus, including lupus kidney disease. And then there's one called I'm kind of rattling them, but I'm so happy that we have some. We never had these before. And then there's one called voclosporin, which is a calcineurin inhibitor that works more on T cells, especially in lupus kidney disease, lupus nephritis. So those are the main biologics, but there's so many more that are actually coming out and like cool mechanisms. So like the science nerd in me is super enthused.
I was about to say, I love the way that you nerd out on this. It's just the best, and it makes for better conversation.
I
So
love
thank
science. Very fun.
Nice. So I think Ryan, I see your hand is up, and hopefully I'm saying
Yes.
your name right. Okay.
Yeah. So I actually had like two questions. The first question though is how guaranteed is the heredity of lupus? So like my mom has lupus nephritis,
Mhm.
and I tested positive for an autoimmune, and so I'm assuming it's lupus. Like, did that question make sense?
It does make sense. Yeah. People ask me this all the time. Is lupus genetic? Right. So not fully, right? So we think people who get lupus have a genetic predisposition to getting lupus, but it's not like there's a gene and if you have this gene, you have lupus, right? So it's more like a polygenetic thing, meaning you have different so there thousands of genes in the human body, right? And they sort of tweak things one way or another. And so there are many hundreds of them that have been associated with lupus. So people who have lupus are more likely to have certain versions of these genes, right? But it's sort of like a drop in the bucket type thing, right? Like if you have one and you have another and you have another, you're sort of closer to tipping the balance towards having lupus. And importantly, it's not just the genes, it's the environment as well, right? So there are environmental factors that can affect whether or not you actually develop lupus. So even if you have a genetic predisposition, you may not ever get lupus if you never have the environmental trigger for it, right? Um, and then the other thing in your case that's really important is you said you tested positive for autoimmune. People
Mhm.
who have family members who have lupus are more likely to have the blood tests that go along with lupus, but not have any symptoms. So you have to have the blood test plus also symptoms to have
Mhm.
the syndrome. So just because you have the blood test that's positive, unless you have symptoms that are related, you actually don't have the condition. And I get that consult all the time. Oh, somebody comes in and they have this blood test that's positive. Does that mean they have an autoimmune condition? And a lot of times it's the answer is no. So like 100% of people who have lupus have a positive ANA, but like 95% of people who have a positive ANA don't have lupus at all, right?
Mhm.
So it's only under certain circumstance that we would actually call this lupus, if that makes sense.
Okay. It does. Is it okay to transition to my next question, or should I pass along?
We want to give everyone some time,
Okay.
Ryan, but I appreciate you. If we have more time, we have 8 minutes left. I want to make sure we cover a few more questions from others in the chat.
Okay.
What was that that came up? But please do drop in the chat because maybe that's something we can answer even post.
Okay.
Oh gosh. Someone says they have neurology, pulmonology, rheumatology, and cardiology all in disagreement. I'm sorry. Like lupus can affect so many like so many organ systems, and then sometimes we as doctors have to work it all out. But hopefully they're all talking to each other.
You caught it. I missed it. Okay, so another question that came in. So thank you, Ryan. What another question? What happens when you're either allergic to or your body doesn't respond to some of the meds for lupus? In this case, for them, it's this except prednisone.
It's prednisone.
Prednisone.
Oh yeah. So to be clear, everyone has side effects of prednisone. Okay, like everybody who gets prednisone has trouble sleeping, their thoughts race, they may gain some weight, they'll get some infections. Prednisone is a very old and dirty drug. It works quickly to bring down inflammation, but it is not the end game. All right. So that's that. But if you have a problem with the medication, then the answer is to try something else, right? Like the really beautiful thing about treating lupus right now is that we have so many options. So always talk to your doctor about how you're feeling on the medications because chances are there's something else that you can try.
So my rheumatologist says that lupus does not affect muscles. Is that accurate?
That is not necessarily accurate. So there are, and like we love charts and graphs in rheumatology, right? So there's a criteria for lupus, and it has like the most common things that lupus patients experience. There's also the disease activity score that we talked about before, which is a part of the low lupus disease activity index, which is what I use to make sure I'm on the right track with the medications, and I change if you're not meeting that. Um, but even though that symptom may not show up in those lists of symptoms, it doesn't mean lupus can't cause it. Lupus can do whatever it wants. Lupus does whatever it wants, right? So, many times lupus patients will have symptoms that are maybe not super common in lupus, but it doesn't mean that it's not related to lupus. The other thing is autoimmune diseases like to come together. So it's not uncommon for someone to have lupus plus also like a myositis, which is like inflammation of the muscles, right? So I think sometimes when you get those symptoms that are a little bit less common, the answer is go back and look for maybe another autoimmune disease that might be overlapping.
Now this question, I'm not sure if you typically share this, but and you mentioned it just now, the criteria. Can you share the criteria scale you use for guidance to change medication?
Yes, that is low lupus disease activity state, LL-DAS. All right, that is the one that I use. Some other rheumatologists may use other targets. So, like some people will use the Doris remission criteria, which is like you can't have any activity, not even 4 points on that disease activity scale. I find that a little bit too stringent because the data supports LL-DAS, so you don't have to get to that remission level. And then also some people just always have a little, low complement and high double stranded DNA, like, but they don't have real activity. So I think LL-DAS works the best for me in a real world environment.
GLPs is the hot topic right now in the chat. I see back-to-back questions about this. New studies using GLPs for inflammation. Do you have any knowledge or research on this?
Yeah, so people are really looking into this, and I think it makes a lot of sense. And I think these are medications that are good adjuncts, meaning they're good medications for helping your other medications work well and helping you feel better, right? So again, when you have excess weight, every 1 pound of body weight puts 4 pounds of pressure on your knees when you're walking, right? So if you're somebody who has joint pain, losing weight is really going to help you feel better with, especially in those weight-bearing joints. Also, fat is an inflammatory organ, right? So fat cells actually make chemical signals that cause the immune system to become more active, right? So, we know this from not necessarily lupus, but some of the other autoimmune arthritis conditions. When people lose weight, their medications actually do better at preventing flare-ups, right? And so that is because we sort of take away that other stimulus that's leading, that's flaming the fire by putting out these inflammatory chemicals called cytokines, right? Um, and then I think the other thing that we're learning is that metabolic syndrome, so, high insulin, insulin resistance also influences the immune cells and how they behave. And so if we can improve that, we may get some benefit with regard to the lupus. So I think it's an area of really hot research right now. I think we're going to be learning more, but I would not be surprised if that is something that does improve outcomes.
And I know that we're about to join rooms again. So
Oh
I
gosh.
think it's going to be my last question, unless there's a little moment when we all come back together. But what gives you hope about the future of lupus care?
Yeah, I think just like the innovation, um, like when I first started doing this, all of my other doctor friends would be like, "Why are you going to do rheumatology? You're just going to give steroids anyway," because we didn't have any other options, right?
Mm.
And now we have other options, right? We have so many things that we can do to help patients and so many different mechanisms. And I think, that is something that gives me a lot of hope that people are going to be living much, much better with lupus than they ever have.
Beautiful, beautiful. Thank you for that. I think we just merge all the other teammates. Thank you. Let's put some hearts, some hand claps, some all the things in the chat for Dr. Blazer. That was a beautiful discussion. Thank you everyone for your questions. I know we couldn't get through all of them, but hopefully when we join back together, we might have a few more minutes for a round robin, lightning round or something.
We're back. Dr. Rose was finishing up one of her answers.
Oh.
Yay!
Sorry, friends.
Do you want to finish, Dr. Rose? We were asking about what gives her hope about the future of MS care.
Oh, yes. So the big push for progression and progression independent of relapses, even when you're stable. And so a lot of those trials are focused on things that can penetrate the blood-brain barrier and go into the brain, because a lot of times we think that progression may be from independent inflammation that's going on within the brain that we don't have access to.
Right. Well, this was so enlightening. We appreciate you so much, Dr. Rose, and so much, Dr. Blazer. Before we close out, two quick important things. First, please, please, please take 60 seconds to fill out our post-session survey. And so those who do will be entered into a raffle to get a little gift card, just as a thank you for showing up for yourselves. And then we'll get an email probably tomorrow morning with the session recaps, and then eventually it'll be all the talks will, except for the group therapy, will be on our YouTube. And so yeah, please, please, please take a moment. I don't know if Timber, you put the survey in the chat, so they can just quickly access it. That would be a big help. Your feedback shapes how we show up for our community, so it genuinely matters. Appreciate you. And then Nicole?
Yes, so this was really, really good. Like, I'm so excited that we're doing this. Second, make sure you come back for our next session tomorrow, group therapy with Charmaine Turner. She is actually our community engagement manager within We Are Ill, and you might have seen her before. If you are part of our Beyond Ill community, you have seen her face all over the place. And if you
Mm-hmm.
are not a part of our Beyond Ill community, you would definitely want to be a part of that, but that's another discussion. It's a guided emotional wellness session, a space to process what living with these illnesses actually feel like. And she's a facilitator who gets it. She's actually, this is her work, this is her career. So same time, same link. Bring your questions, anything that pulled at you today. I'm sure it's going to be great for tomorrow's discussion as well. Bring a friend, somebody
Mm-hmm.
you're like, you're tired of explaining this. I'm like, hey, just join this call with me because it's going to help us have a better dialogue and conversation. And let's just keep the conversation growing within our network and our community so we can all be on one accord and empower ourselves.
Yes, absolutely. Now, is that Wendy Williams who's doing our fourth session in the Hey girl.
Yeah.
Hey Wendy, stay tuned for session 4 with Wendy Williams for Ask the Case Manager. Thanks for showing up, Wendy. And thank you all for showing up for yourselves and just being a part of this community. It really means a lot. Um, Hopefully you got something from it. And please, please, please invite your homegirls, your partners, your spouse, your caregivers, and take the survey. I think that's it for now. Thank you all so, so much. Bye.
Bye.